Our wonderful co-chair for Sacramento since 2012, Dr. Arevalo from Sutter ITA, becomes some magnificent work here.
Well, thank you. Thank you all for being here. This is where we hold our monthly University of Best Practices RightCare meeting here in Sacramento, we call it Capital. So I have about 40 slides. I'll follow and just not show them. But this is really a thank you. I'm here mainly to say a thank you both to Hattie, who everybody's been thanking today for bringing RightCare to Sacramento. Also to Parag, because Parag was the first co-director, as we heard, along with me. And then I want to thank the people at Table 5, which is, I think Terry Hill in particular, and Don Hufford, who have been very, very instrumental in working with us in the RightCare initiative, and Mary Firmisen, who continues to be, supportive and has helped bring us together. And again, you saw that we're celebrating our 4th year. One of the things that I wanted to talk about briefly is that we decided to create a product in RightCare, and with the help of Susan Ivey, who has done a marvelous job again with, and Amanda Liu, we put together a little card. We actually stole this idea from Gunderson. We had a presentation, one of the many RightCare presentations that came to work with us and share, collaborate, this collaboration even across states. And they had a simple pocket card that they used for their clinicians to identify the guidelines. And as you know, one of the challenges that we all have, especially clinicians, if you're affiliated with a large group, you may have the opportunity to have guidelines that you can turn to, and they may be available handily, and you may be able to look at them when you need them. We found that presentation said, hey, this is a great idea. Why don't we steal it, and using the Joint National Commission's 8, JNC 8 criteria, in 2014, again, working very closely with Susan and Amanda, we put this thing together. We printed over 2,000 of these, and we said, look, you can use these, even if you have guidelines in your institution, which we actually had in my institution, but these are handy because they're JNC 8, very specific. We did make a couple of changes so it was not completely JNC 8, and we found that it was very well accepted. We found that people liked it. Many clinicians came up to us and said they used this, and so again, it's really a thank you, because RightCare now created a product that's being used. I know that LA has printed them. We've had, like I say, 2,000 LA, and then CAPG, we heard, is interested in taking this as well and printing similar, probably updating it a little bit, because again, this is 2 years old. And we wanted, again, to highlight some of the work that RightCare continues to do. We hope to continue to work together here with our local capital region. Just like San Diego, we have community clinics, we have the military, and Matt was here, I think he's gone. Oh, there he is, and Matt needs to join us, and so we have great contributions by our systems in the county and the community clinics. Olivia Kusuri couldn't be with us, but she's our public health officer and attends regularly. And Jessica, who is with the state, comes and gives us her support as well. So I'm going to thank Jessica. So again, this is really meant to be a thank you, and to say that we continue to work very hard in the capital region, and that we want to be able to be with you next year again. So thank you.
So in Los Angeles, our co-chairs couldn't join us today, but we have catalyzed a project that United Healthcare is doing with Ralph's Groceries and Jan Hirsch at UCSD's School of Pharmacy. They're just going to give you a 5-minute overview of that. Everybody can participate in it. and then we're going to turn to our health plans panel.
Okay, now I know why everybody was having trouble with this. Good afternoon, I'm Jan Hirsch. I am with the University of California, San Diego School of Pharmacy, but I am standing here for the University of Best Practices of Los Angeles. So Hattie asked me, I am still at UCSD, Hattie asked me, could you go to Los Angeles on a regular basis? So of course I do go to Los Angeles on a regular basis. This is facilitated because I do live in Orange County between the two. So we've been working for a couple of years. We told you last year. We want to give you an update on this project. It's reducing hospitalization utilization. That's both hospitalizations and ED visits, which we've seen there are differences in trends. But the key thing here is we're integrating the community pharmacists, which is something that hasn't been done well. So I'll give you a real quick update of what the project looks like and where we are, and then Rebecca's going to give you a couple of key learnings that we've had so far. Here's the right. It's just something about this, isn't it? Need a little bit of fingernail polish there. Okay. Yes. Okay. So here are the players. The project is being funded by United Healthcare. Jeff Mason, who is the Senior Medical Director of the United Health Plan, sends his regrets that he cannot be here. And I have to say, we have to thank him and thank him and thank him. His heart has been in this. He has been persistent with his bosses all the way up to the top of United Healthcare and found the funding for this project. So we're just very, very thankful for him. On the Ralph side, Rebecca Cupp and Lloyd Serena have been integral in this. PIH, which is Presbyterian Intercommunity Hospital, which they are in Los Angeles. Gloria Noel is a nurse, and she is in the case management team, which is integral to the project. It's between community pharmacists and case management in the inpatient setting. Also, Steve Chin couldn't be here today, but USC isn't involved in this and his past experiences. And Mary Hermanson and her team also was on the HSAC. The goal is we're trying to reduce hospital reutilization, whether that's hospitalization or ED visits, by adding the community pharmacist to the care team. We're trying to evaluate this community pharmacist-based medication reconciliation program. We call it MedRec, but it's actually more than that. It's a medication reconciliation and a complete medication review by the pharmacists. And we're hypothesizing that having patients seen by the community pharmacist after their discharge will reduce hospital utilization. We're skipping the polling questions. Just as a visual, what happens is, what's going to happen is that patients are screened, they're in the inpatient, they're screened on a daily basis, and we're looking for patients that are at an elevated risk of hospital reutilization. We're using the LACE tool to help us identify who those patients might be, and or they are on medications that have been shown to be associated with a higher risk of either ED visits or rehospitalizations. And they have to be basically adults in English or Spanish speaking, which I think is important. The pharmacists that are going to be implementing this are bilingual and fluent in both English and Spanish, which is important. Once the patient gives consent to be in the program, then they are randomized. And they're either randomized to be in the PharmD MedRec program or usual care, whatever that is, for PIH. We're trying to get 240 patients in each group, and then we will follow those in this fashion. So here we're trying to show you what is going to happen. So if you take the top row, that's PIH, the healthcare, the hospital, and the Rouse pharmacist is sitting at the hospital there, and we depicted it that way because the Rouse community pharmacist is going to have access to the electronic health record within PIH, and that's a huge step for this integration. So they'll be able to take the information to Rouse, then the intervention will be done at Rouse from the pharmacist reaching out to the patient. The second row is where the patient leaves the hospital, they go home, the patient is then the pharmacist is contacting the patient within 72 hours, providing this MedRec, but also the complete medication review. All that information, complete medication listing, is given to the physician, their PCP. The pharmacist is also following up with, are you going to your PCP follow-up visits, etc. And then a real key point is this bottom line. there's a specific communication back from the pharmacist, back into the hospital, to that nurse case manager. And we haven't seen that done, at least within the literature, and this is a big piece of this. So, but there's a lot of things the pharmacist can't deal with. All the things we've talked about here that make a big difference will make a big difference in getting that information back to the case managers. And we'll track what the case managers did with that too. So that's it done. Only question we want to ask you. Timeline, Jay, UCSD did fund it. We're now to the point of all the contracting amongst everyone. We're doing the IRB protocol. Hopefully that'll all be done kind of the end of the year here. And we're targeting enrollment in March. We should be able to report back fall 2018 on some results.
And which health plan patients can participate?
And I wrote that on a piece of paper to remember I would say it, and I didn't bring it. Any health plan patients can participate. There is no selection. United Healthcare is funding it, but it's all patients. It's all comers. There's no discrimination amongst them. Thank you. Okay, so we have learned a little bit.
Oh, you can do that.
Okay.
I don't want to have to.
I've got my thumbs.
So it's taken us 2 years to get to this point. This has not been a quick process, but we have already learned some things. We've had one person retire on the team already, and Jan and I are determined not to do that before we're done with this. But we have learned some things already. It is complicated to work with these different organizations that all have their different roles to play that are not integrated. And so we have learned a tremendous amount through that process. Hopefully we will be able to share a lot more of that in the future with you. And then also we found that some of the measures that we were going to do really were not the best way to look at things. And I have, so this will rival any of Alan's slides. This is the relationship among the partners, right? It is very complicated. The way that the money is flowing, the way that the agreements are being done, even what agreements do you need to have. There are even differing opinions among the different collaborators on what agreements do we need. Is it a BAA? Is it a services agreement? What kind of credentialing, et cetera, are required? So great amount of learning through that process. We're not quite finished with it yet, but we're making good progress. And then the other thing that I mentioned was some of the original ideas of what we would measure, not just the readmissions within the 30 days, but also what's a discrepancy and what are we measuring, what are we looking for. It turned out that looking at the medication lists from the various entities, whether it was PIH, whether it was the patient, et cetera, those didn't always drive, very often they don't. But how are you counting what those discrepancies are? And it really, at the end of the day, we decided that was not the best thing to measure, but rather looking at the medication-related problems only. And so those are the pieces of information that we will capture to report out on, in addition to the readmission rates. And that's our summary very quickly. I want to say one other thing really, really fast. Community is obviously where we reside. And so, expanding access is extremely important to us. So this is an opportunity for us to follow those patients back into the community, hopefully keep them in the community. I look at everything, as some of you know, through a caregiver's lens. So we're trying to make this as user-friendly for the patients and their caregivers. And just in case any of you are from the Los Angeles area, or even San Diego, all 80 of our pharmacies for the whole week without an appointment anyone can get a free blood glucose screening this week. So just pass the word around. We'd love to see a lot of people show up in the community.